morning. Thank you all for being here. First of all, I'd like to thank Dr. Spadaccio for helping me arrange this, and Mendon Arts and Literature. Thanks to the speakers before, Dr. Wei Tam, Dr. Lawler, and Dr. Bemmel. And most importantly, thank you all for being here, because with patient education, we have better outcomes. And my name is Srinivas Rajshekar. I'm one of the cardiac electrophysiologists here at the University of Cincinnati. And I'll be talking about what happens when atrial fibrillation keeps returning. What are the next steps? What are the next steps in our atrial fibrillation treatment pathways? This is really important. Atrial fibrillation is a national health concern. It's estimated about up to 5 to 10 million American adults are diagnosed with atrial fibrillation. That's about 4% of the population. There's a 2 to 5 times increased risk of stroke in patients with atrial fibrillation. A 5 times increased risk of heart failure in patients with atrial fibrillation. And we heard briefly about medications, and unfortunately, 65% of our patients end up discontinuing medications after 2 years for one reason or the other. It may not work effectively, they develop side effects or tolerance to the medications. And it's interesting to note that less than 5% of patients undergo atrial fibrillation. I always found this slide interesting. This is actually a slide from 1991. What this is showing is the prevalence of atrial fibrillation in our country. Back in 1991, they predicted that by 2050, there'll be 5.6 million patients diagnosed with atrial fibrillation. But this is 2026, and we've already reached that 5.6 million number. So atrial fibrillation is unfortunately rapidly growing in our country. And this puts a lot of economic burden on the patient as well. If you look at the related healthcare costs because of atrial fibrillation, the average patient is spending about $7,000 to $8,000 for their management of atrial fibrillation, inpatient visits, outpatient visits, ER visits. And so this puts a lot of economic and financial stress on our patients. And it's been previously discussed that atrial fibrillation, this is a progressive condition. It's a progressive disease. And I think that's one of the major take-home points today. There's different stages of atrial fibrillation. Stage 1 is when you're at risk for atrial fibrillation. You have these risk factors, but you don't actually have atrial fibrillation. Then stage 2 is when you start to have these structural electrical findings in the heart, which predispose the patient to atrial fibrillation. And then patients then progress to stage 3 when they actually are diagnosed with atrial fibrillation. And within stage 3, there are different types, as Dr. Lawler has mentioned nicely. You have paroxysmal atrial fibrillation that comes and goes within 7 days. Persistent atrial fibrillation, which lasts for more than 7 days and lasts up to 12 months. And then long-standing persistent, where it's more than 12 months in duration. And then you have permanent atrial fibrillation, where the physician and the patient decide that no further attempts at rhythm control will be attempted. So it is very important to note again that this is a progressive condition. And 17% of patients progress from paroxysmal atrial fibrillation to persistent atrial fibrillation in 1 year. And patients with paroxysmal atrial fibrillation who undergo catheter ablation are up to 10 times less likely to progress to persistent than those on antiarrhythmic therapy alone. So again, it's a progressive. I keep wanting to emphasize this, and you'll hear in my other talk too that we really need to understand that this is a progressive condition. So there are certain things that we can do. There are certain non-modifiable risks that we have, genetics, males. The older we are, they're at a higher risk of atrial fibrillation. There's nothing we can do about that. But there are certain modifiable risks that we can work on, such as obesity, lack of fitness, controlling your blood pressure, sleep apnea, alcohol, limiting your alcohol intake, diabetes, controlling your diabetes. These are modifiable risk factors which will delay the progression of atrial fibrillation. So this is just a patient, made-up patient. I don't know why I thought of Benjamin Harrison, but no relation to our 23rd president. But this is a typical patient that I see in our clinic. This particular gentleman is a 62-year-old male. He has a history of atrial fibrillation, high blood pressure. He comes to the clinic with more atrial fibrillation episodes. 2 years ago, he was diagnosed with paroxysmal atrial fibrillation. That's atrial fibrillation that comes and goes. At that time, he was feeling intermittent symptoms of shortness of breath. He was started on flecainide, which is an antiarrhythmic medication. And he did well for a whole year. But more recently, he's been having more episodes, and they're lasting longer. And he did have an episode where he had to undergo a cardioversion. That's an electrical shock to reset the rhythm. He went back into normal sinus rhythm, and now he wants to know what's next. What do we do next? Why does this atrial fibrillation keep occurring? This is what a cardioversion is. Basically, you have the patient on a table, and we have these two patches here, which are connected to this machine. And the patient is asleep under anesthesia. And this machine delivers an electric shock, and that resets the heart rhythm. The patient doesn't feel it, he's not aware of it. And that will most times successfully restore the heart rhythm. But oftentimes we have to understand that cardioversion is not a cure for atrial fibrillation. After you have a cardioversion, the recurrence of atrial fibrillation doesn't mean failure of care. It often reflects the biology of the disease. Cardioversion can restore sinus rhythm acutely, but the triggers and the substrate for the development of atrial fibrillation, they remain. So with cardioversion, you have these cells which are firing. And then when you shock them, they go into a resting phase, kind of a dormant phase, but they can reactivate at any time. Sometimes it takes months or years for it to reactivate. Other times we shock the patient in the EP lab, we wheel them outside to recovery, and then they're back in atrial fibrillation, fortunately. So now we have to think of a new strategy. What do we do after a cardioversion that keeps coming back? So we have to be mindful not to repeat the same strategy over and over. We have to try to address the underlying conditions or contributors. So why does atrial fibrillation occur? So most AFib episodes are initiated by firing from the pulmonary veins. So this is the heart right here that's sliced in half. You have the upper chambers, the right atrium, the left atrium, the right ventricle, and the left ventricle. And then there's pulmonary veins, which bring blood from the lungs into the heart. And where the pulmonary veins meet the atria, that's where these triggers are present. These triggers are firing. And when they enter the atrial chamber, the heart chamber, they cause the irregular heart rhythm, the rapid heart rhythm. And so this is our are focused. So even after a cardioversion, these triggers still remain. And with antiarrhythmic therapy, they suppress these firing from the pulmonary veins, but sometimes only partially, and sometimes they may not be effective. So even if you restore sinus rhythm, the spark is still there. A term that throughout med school and fellowship residency you keep hearing is AF begets AF. And what happens when you have repeated atrial fibrillation episodes, there's a change in the electrical system of the heart. The tissue and cells, over time, with repeated AF, they adapt and they become more prone to beating faster and recovering faster, allowing for more repeated fire. And the tissue around it develops different conduction properties, and they develop the ability to fire and also sustain the atrial fibrillation. And so this makes atrial fibrillation easier to reinitiate and sustain. And so the term AF begets AF is a term that we hear in our field quite often. And so you talk about the electrical changes, there are also structural changes that happen within the heart. And this is you have atrial fibrosis, and over time, the tissue undergoes fibrosis, developing scar tissue, the atrial size becomes larger, and you lose the normal conduction pathways. And this creates a substrate that maintains atrial fibrillation. So not only now do you have a trigger from the pulmonary veins, you also have, because of the progressive nature of the disease, over time, the changes and remodeling of the tissue in the heart, you develop a substrate that can make this atrial fibrillation self-sustaining. And instead of going from a state where your paroxysmal atrial fibrillation where it comes and goes, over time, it will become a situation where you're always in atrial fibrillation. You go from persistent atrial fibrillation to long-standing persistent, and unfortunately to permanent atrial fibrillation. This is just a diagram showing the electrical changes in the heart and structural changes over time lead to progressive atrial fibrillation, especially if not controlled early on in the disease course. So not only will you have these triggers from the pulmonary veins, but within the different walls of the atrial, the posterior walls, you'll have different foci and areas that can sustain the atrial fibrillation. So how do we prevent this recurrence? First, you need to go back to lifestyle modification. And we have to look at what contributes to this recurrence. And that's going back to things we talked about, controlling your blood pressure, working on your overall body mass index, your weight. Sleep apnea, if you do have sleep apnea, treating sleep apnea is a key finding. Alcohol use, limiting alcohol use, controlling your diabetes, treating your heart failure. All of these continuously remodel age. And if these are not controlled, recurrence almost becomes inevitable. No matter what we do, if we don't treat these underlying conditions, we're going to have a difficult time controlling the progression of the disease. So there are certain limitations of cardioversions and medications, right? Cardioversion, high term and short term, it's successful, but there's a high recurrence if you don't actually treat the actual substrate. Antiarrhythmic drugs, they reduce the recurrence, but they're not always 100% effective. And side effects limit long-term use. And oftentimes patients have a difficult time trying to take these on a daily basis. And neither of these therapies eliminates the underlying mechanism of atrial. So what's next? So our patient wants to know what's next. So what do we do beyond cardioversion? What do we do beyond antiarrhythmic medications? So what's important was at the center of modern atrial fibrillation care is what we call shared decision making. We want to involve our patients in the care. We just don't make the decision. We make it with our patients. So basically, shared decision making is when the patients and clinicians work as a team to make care decisions. This increases the patient knowledge of the disease and it helps with the satisfaction of their care. What we do is we define clear goals for treatment. We align the health decisions with the values of the patient. And our discussion really focuses on what your symptom burden is, the impact on lifestyle, how are you tolerating your medications? And it's important to understand what are the patient's goals. Fewer episodes, avoiding medication, improving exercise capacity. It's always important for us and to the primary care physicians in the room to don't think in terms of atrial fibrillation. Patients thinking, can I live normally again? And so we want to align our treatment with what matters to our patients. So it's a strategy discussion. Do we stick with rate control? Do we go on to rhythm control? What type of atrial fibrillation does the patient have? Paroxysmal, persistent? What is the likelihood of success in any one of the strategies that we discussed? What are the alternatives? Our patient tried medications, we tried cardioversions. Is it the right time for an ablation? So what I always like to remember, not every patient needs an ablation, but every appropriate patient deserves the discussion. And so this is a tailored decision. It's not a one-size-fits-all approach. And so that's what the next steps are, why and how atrial fibrillation progresses. And so in my next talk, I'll talk a little bit more about what exactly atrial fibrillation is and any questions?
Oh, yes, I have questions from online.
Oh, one minute, please.
You mentioned about shocking your heart back in the rhythm, to get it back to normal. But you said don't last. What's the reason of putting it back in the rhythm if it don't? It's just temporary.
That's a good question. The question was sometimes when we do a cardioversion, the question is it doesn't last. So what's the point of doing it anyway? So there's several reasons why we do it. Number one, in the acute situation, you have a rapid heart rate. Sometimes atrial fibrillation, you can have atrial fibrillation with normal heart rates and atrial fibrillation with fast heart rates. It's important to get them back into normal rhythm to control the rapid heart rate. Because we don't want your heart rate to sit in the 140s and 150s. So that's a quick term solution while we prepare the patient, while we do the workup necessary to plan for the next step, if it involves an ablation or not. So that's one of the reasons. Other reasons are, and I'll talk more about this after an AFib ablation or after some of these pauses that we have. For example, if the patient has very uncontrolled hypertension or insignificant heart failure, we want to be able to, we put them back in the normal rhythm. We treat those conditions first before we offer an ablation. So we want to make sure that the patient's underlying conditions are treated well and under control prior to considering other steps such as ablation. Hopefully that answers your question.
If your heart rhythm is already in bradycardia, would you be a candidate for that?
Yes. The question was if your heart rhythm is slow or bradycardic, would you be a candidate for an ablation? Yes, because your heart rate can be slow and still be in atrial fibrillation. So bradycardia by itself is not a contraindication to atrial fibrillation ablation. But we, again, put all different things of the patient together, and we come up with a targeted patient solution.
So does multiple cardioversions cause damage to the heart?
I'll repeat the question just for good film, and it's multiple cardioversion actually create the damage on the heart. So that's again a good question, and a question that often comes up. What I tell my patients, being an atrial fibrillation, rapid ventricular rates, that will often do more damage than the cardioversion itself. Yes, there is some small stunning of the atrium, but usually that recovers. So I think it's always a risk versus benefit discussion, and being an atrial fibrillation is more sometimes, in some patients, more dangerous than having repeated cardioversions.
Is Farapulse a better procedure for ablation and should also add the implant to prevent blood clots?
That's a good question. I will, if you can save that question for the next talk, because I'll be covering a little bit more about ablations in the next talk.
Okay.
I had the ablation first,
Yes.
but it came back, so then I had the aversion after that, and I'm doing well. And you talked about working with your doctors as a team. How, and I've been monitored with my outside heart monitor, and I'm doing well. How often should I expect to go through that monitoring process?
That's a good question, and the question was one of our patients had a atrial fibrillation ablation, and then she did have a cardioversion after that, and she's been in normal rhythm since. And the question is, how often should she monitor? And what we typically do is that it depends on having a loop recorder really does help in monitoring our patients. Some of our patients are aware of their symptoms, others are not. And the patients who are aware, they can call us, they can tell us, hey, I'm back in atrial fibrillation. I'm less worried about those patients. It's the patients that I'm unaware of, they are unaware about their symptoms. Those are a little bit more concerning, and those patients, devices such as loop recorders are beneficial because we are alerted when a patient goes into atrial fibrillation. We look at the overall burden of atrial fibrillation. Dr. Tam showed one of his patients had a nice graph. Not every patient is able to do that. But if you have a monitor, every month we do get a report of how our patients are doing. And if we see a significant rise in the amount of atrial fibrillation, we'll call the patient in earlier. But typically, after an ablation, initially we may follow for 6 months initially, and then after that, it may be once a year appointments. And we also have our, it's a team, right? So you're going to be seeing your primary care physician. That's why I try to spread our patient visits apart. If I'm seeing a patient yearly, I try to make it such that they see at least their primary care physician or their general cardiologist in 6 months. And so she's seeing someone in at least the 6-month time frame. But often seeing the electrophysiologist, it may be, if the patient's stable, it may be just once a year. And especially, we have confidence in our monitoring solutions that may help with delaying the visits. So we're not burdening you by trying to come frequently. Yes, thank you.
So you're saying so AFib begets AFib, and it gets more challenging to actually cure the AFib as it progresses, but only, like you said, 3 to 5% get ablation. Are you going to be advocating for that earlier on in the process for patients?
That's a good question. The question was, as I said, atrial fibrillation is a progressive condition, and the only less than 5% of patients statistically are actually getting ablations. And is there any role in advocating for earlier ablations? And the answer is yes. I think the data is strong that shows that the earlier in the disease course that we do an ablation, the better the outcomes. And I'll be talking a little bit more about this in my next talk, but paroxysmal atrial fibrillation success rate is about 80 to 90%. But when they advance to persistent atrial fibrillation, that drops down to 60%. So the data is there that the earlier that we do the ablation, the better the outcomes. It's not really defined how early it's really, but we know from our more recent trials that earlier when we do an ablation that halts the disease progression, better outcomes. Yes, sir.
You've developed a dichotomy of treating heart rhythm or a heart rate. This is a language question. What does pulse mean to that dichotomy?
Okay, that's a good question. The question was, what is heart rate and rhythm, and what does the pulse mean with regards to heart rate and rhythm? So the pulse, when you feel the pulse, there's two things that we are feeling for. We are feeling for the rate, we're counting the rate, and we're also assessing the rhythm. So usually a normal pulse rate and rhythm, so pulse is two parts. When you feel your pulse, the normal rate should be between 60 to 100, right? And it's usually regular. When it happens in a time like a metro, it's pretty timed. You have one beat, and then when you have atrial fibrillation, the rate can vary. You can have atrial fibrillation with a normal rate, with slow rates, with fast heart rates. But what differentiates atrial fibrillation is the pulse is irregular. So you can have irregular. So the term that is often used is irregular pulse. So it's a very irregular pulse that tells you that the patient is in atrial fibrillation. And then it's important to note the rate. So when you're checking the pulse, we're asking you two things, rate and the rate. Does that answer your question?
Let me say,
Yes.
you tell me whether I understand.
Yes.
I have a pulse,
Yes.
say it's 70.
Okay.
I can go out and run sprints and I can get it up to 120.
Yes.
But I don't determine that, I don't feel that pulse being irregular, either at 70 or 120. Because when I measure it, it's there. It's not irregular, it's actually being measured in response to stuff like that. How does that help me know whether or not atrial fibrillation is occurring? I don't understand.
Right. So atrial fibrillation really is more of a rhythm disturbance. It can affect the rate, but it's more of a rhythm. So you have to think in terms of if you're measuring your pulse, it's constant. It's unlikely that you're in atrial fibrillation. But let's say when you're measuring your pulse and it's irregular, like sometimes you're hearing it go fast and then it stops for a while and it goes fast, stops. That tells you that you're in atrial fibrillation. So when your pulse is 70, it's constant, you're in a normal rate. But if your pulse is 70 and you're feeling an irregularity, that could be atrial fibrillation. And if your heart rate goes 120, but your pulse is constant, that's probably what we call sinus tachycardia, a normal heart rate response. But if it's 120 and it's irregular, then that tells you it could be atrial fibrillation. Does that answer your question a little bit more?
Yes, I'm just confused.
Okay, maybe after the talk, I can probably try to. I'll touch base with you later today. Yes.
The loop forward, that's implanted, right?
Yes, that's the one that's implanted under your skin.
Can you have a loop recorder and an Inspire or
Sorry, I can hear the question. Are you asking for if the loop recorder and Inspire interact?
Right.
No, there's no interaction between a loop recorder and Inspire. Good, thank you.
Just a couple more have popped in online since you've been chatting. Is bundle branch blockages and AFib connected?
So the question was bundle branch block and atrial fibrillation. So there are two different entities. A bundle branch block is basically a slowing of the electrical impulses down the normal electrical conduction system. So that's different from atrial fibrillation. But patients with atrial fibrillation can have bundle branch block.
Is remodeling of your heart due to AFib causing your heart to be weaker?
So what the remodeling does, yes, there are changes to the heart, and there's structural changes, electrical changes. And if the atrial fibrillation persists and there's no control with the heart rate, yes, it can cause the heart function to become weaker over time. So indirectly, yes, it can if the rate is also fast. So the answer is yes.
That's